So the first question when you're confronted with a patient with disc edema is what is actually the other eye. So whenever you have a disc pathology in one eye, and probably that's true for glaucoma also, you're really worried about what the other eye is happening to, and because that's going to give us clues also to what's happening to this eye. So if you have unilateral, that is the other eye is absolutely normal, so then you're basically focusing on this eye and trying to find out whether this is hyperemic or pale. And if you have the other eye which is showing there is still disc edema or suggestion of a disc edema, you know it's a bilateral pathology which you're worried about an intracranial problem, and the other eye may actually have some signs of optic atrophy, so showing that there was something that happened to the other eye and it's now happening to this eye. So probably this eye will have the fate what the other eye had. So it's important for us to understand whenever you have an optic nerve problem, that's what's happening in the other eye, because it will give us an overview of the pathology that could be. So you can have a lot of different causes. Many of the bilateral causes may be asymmetrically in presentation. So may actually have a unilateral presentation now and may go on to bilateral involvement, particularly seen in cases of papilledema where there may be asymmetric papilledema. You may see the early papilledema in one eye, and in the other eye probably maybe because of the septae, the pressure transmission takes a little while and you are not able to see it, and subsequently you will see edema coming up in that eye also. But then the most important unilateral causes you're looking at is optic neuritis, which was discussed a little while back, particularly presenting as papillitis, ischemic optic neuropathy. So in some substance, but much of the disc edemas are because of this. Of course, the one thing you need to be sure of that is it actually true disc edema, because very often we keep treating particularly children who may be a little hyperopic as disc edema when it's actually pseudo disc edema. The other causes in the list like Leber's, diabetic papillopathy, compressives, venous congestion, and associated with uveitis, usually it's not so difficult to catch them, but it can always be a challenge. So first you need to see whether any of these presentations is actually true edema. So if you look at any of these, all of these are giving a suggestion of edema, but all of them are actually pseudo edema. So none of them, this is a classical pseudo disc edema. This is a disc hypoplasia. You can actually see the double ring sign coming up here. These are just myelinated nerve fibers here. And this is also a pseudo disc edema, smallish disc where the nerves are just piling over it, and that's why it appears. So of course the first most important thing to actually identify edema is to see it in 3D, a stereoscopic examination, but using any of 90D or 70AD or whatever you're most comfortable with. So the difference is that there is no elevation in a pseudoedema. The nerve fibers may actually pile up at the discs because it's actually called a papilla to start off with. So you have the nerve fibers humping up when it exits the disc, but they quickly come down and settle at the retina, and therefore it appears to be an edema, but it's just the nerve fibers. There are no dilated capillaries, there is no hyperemia of the disc, no obscuration of disc vessels, and there is a lot of abnormal pattern that we saw in the first photograph there. So you can see an abnormal peripapillary vasculature, which is suggesting that it's a pseudo disc edema. When you have unilateral disc edema and you're sure it's unilateral, you need to have an idea whether it's a hyperemic cause or it's a pale disc. So hyperemic cause may be papillitis, asymmetric papilledema. You could have compressive neuropathies, which is causing a congested disc, or a local retinal cause for it. And a pale disc edema usually is an ischemic origin disc edema. So we quickly run through a few important features of optic neuritis. We've discussed them in the morning also. Dr. Ambika talked about them. You essentially have a variable amount of diminution of vision. You may have pain on eye movements, particularly looking superiorly, which may be variable actually. It's usually unilateral. In fact, a typical optic neuritis would be unilateral. Of course, in that condition, you will see an afferent defect. You have features like a Uthoff's phenomena or a Pulfrich phenomena, and you may have a disc elevation, a hyperemia, a couple of splinter hemorrhages, some amount of vitritis just anterior to the disc may be present. The visual fields may be variably affected. You often have centrocecal scotomas. They can mimic any kind of pathology, or sometimes even confused with glaucoma. Of course, you have color contrast affected. The color is usually more affected compared to the visual acuity, and you have other phosphenes or positive symptoms that the patient may complain of. In papillitis, you will have a disc edema, which will be leaky, so it's important to see and identify. Sometimes you may require a fluorescein angiography in one of the cases I'll show you. And you may have a variety of causes, the most common being demyelinating, which we will call typical, but there are a lot of infective and non-infected infectious causes which may be responsible for the optic neuritis. The ONTT gave a good idea as to the treatment, IV methylprednisolone. In our center, we've been using dexamethasone, but a high dose IV steroid to reduce the edema, improve the vision. Oral steroids have shown to have a higher incidence of recurrence, so actually is a no-no. If you are suspecting MS, then in conjunction with a neurologist, the role of interferons. The importance of imaging is, one, to rule out other causes. If you're suspecting multiple sclerosis, the prognosis or the chance of the patient becoming or developing multiple sclerosis would be known. So when would you image? Theoretically, I would say every patient, but if it's a recurrent optic neuritis, patient is keen to know about long-term prognosis, history of other neurological history, atypical cases, sometimes in children, especially if they do not improve, spine if you're suspecting an NMO, and of course, if there are any neurological lower limb signs present. So this was a 24-year-old male presented with diminution of vision one eye followed by the other. You can see the vision is subnormal, the discs were essentially normal. You can see a variable field effect affected, you have color contrast affected. Well, we diagnosed bilateral retrobulbar neuritis, gave pulse steroids, patient improved significantly. So the question is, should we actually neuroimage? We would probably, because he had some atypical features, there was bilaterality, a mild disc pallor when he presented, and the recovery of vision was not so rapid as we would have thought. And that's what presented with, there was a tumor in the patient. So important to know that all rules that we talked about are for typical optic neuritis. The moment you have something which is away from what you would typically think, a young patient, a unilateral affection, sudden loss of vision, start plateauing by second or third week, starts improving, improves fairly quickly with IV steroids. If that is not the case, it's an atypical feature, you start thinking of something else. Pale disc edemas are ischemic in origin, and NAION is one of the most important condition that we see and is increasingly becoming important because the increased incidence of systemic disorders that are there. So the patient will come with blurred central vision, mild pain, there may be a variable affection of the vision, you would tend to have an altitudinal field effect. There may be a little bit of disc edema which is usually pale. The cup is obscured, there may be a few splinter hemorrhages, there is a delayed filling of the optic nerve head, which is all pointing towards NAION, and the most important thing you're looking for are the risk factors, which would be like diabetes, hypertension, hyperlipidemia, sleep apnea, nocturnal hypotension. So patients with hypertension using their antihypertensives at night may actually present with sudden loss of vision in the morning. A small cup, hypercoagulopathies, anemia causing ischemia, migraine, smoking. So these are the important risk factors you ask for when you're thinking of NAION. There is still limited management that is available. Of course, the most important thing you need to do is to control the risk factors that you feel are responsible. No therapy as of now has of proven benefit. Steroids were being used, and it was considered that in non-diabetics it may be helpful, but in a recent published study we did not find them to be effective. In fact, we found no difference in the ones we treated with steroids, and we did not. Optic nerve sheath fenestration is of course a no-no, and recently there is a trial ongoing of which is also happening in India, the QPI 1007, which hopefully gives us potential for treatment of NAION in acute conditions. It's important to identify arthritic, although we tend to see very few of them. But the important things when you're suspecting ischemic and arthritic is that this visual loss is very, very severe. There is associated scalp tenderness, jaw claudication. There'll be history of weakness, of myalgias. The edema is chalky white, a very severe edema. And as I said, the visual loss is very severe. The importance is that it is caused by occlusion of the short posterior ciliary arteries, and you have a lot of associated disorders that you need to identify. Again, the importance being that there is a major chance of the other eye getting involved within a couple of weeks or so, and a long-term effect to life is also there because this thing is happening everywhere. So consider arthritic or GCA in advanced stage patients, those who give a history of headache, scalp tenderness, have transient visual obscurations prior to the problem that they presented with, and of course the important investigation to do is an urgent ESR and C-reactive protein. If they are elevated, then a very high chance of arthritic AION. You need to manage it in an emergency to prevent the other eye getting involved. Although the standard of care is oral therapy, about 1.5 milligram per kilogram body weight, but people have even given IV methylprednisolone in the optic neuritis doses. And it's important that this treatment continues for a fairly long period of time, sometimes up to 1 to 2 years, and you taper the treatment or the steroids gradually based on the ESR CRP responses. There is a role of immunosuppressives in the long-term treatment if there are steroid-related problems that are happening in these patients. So it's important if they are older, more than 65 years, you're thinking of arthritic, severe visual loss, associated symptoms, systemic symptoms like jaw claudication, weakness, weight loss, increased ESR, CRP, and a severely pale disc. So these are red flags for arthritic. Otherwise, the bulk of them present with non-arthritic, which is, of course, important to identify the risk factors. The other causes of disc edema like Leber's, usually they present to us much later by the time they had bilateral involvement, but sometimes if they present to you early with one eye involvement, you'll see in young, predominantly in males, you have rapid monocular visual loss, and the loss of vision is in a stepladder pattern, so you'll have loss, it'll slightly improve or be stable, and then after a while it'll again reduce. In the presence of centrocecal scotomas, which are the classical field effects that you see in them. If they present to you acutely, you can see circumpapillary telangiectatic microangiopathies and a prominent peripapillary RNFL. So this would be the feature of a Leber's that you would see. The other eye would classically be normal, but there would be no dye leak on the disc. So if you are suspecting, you would want to see that there is no dye leak on the, from the disc. The management is, of course, to avoid toxins, that is smoking and alcohol, the most important thing. It's known that many carry the Leber's gene, but all don't get affected. So it's possibly an insult, a stressful event that triggers the LHON. So it could be smoking, alcohol, stress that we all are facing all the time. So, and it's easy to avoid, ask them to avoid it, but difficult to do. So the important thing is to avoid anything that can stress the optic nerve. Some of them improve spontaneously. Idibinone is the now recommended therapy and has orphan drug treatment status for LHON in the EU, but is yet to be introduced or to be permitted in India. The ODEMs or the optic disc edema with macular star would have multiple possibilities, most important being neuroretinitis, and you need to do a systemic screen to identify other risk factors. And like I said, it's important the moment you have this to identify whether the other eye slowly gets involved, because they may be misdiagnosed with a papilledema or an IIH, and Leber's idiopathic neuroretinitis, which improves spontaneously. So this was one patient which I recently saw. A small undilated disc examination made us and give us an appearance that it's probably optic neuritis, sudden loss of vision, right eye, mild pain. But the moment you do a dilated exam, you can see that there are a lot of changes in the choroid, and the patient actually was of choroiditis presenting with disc edema. So any patient with disc edema, dilate, do the disc examination stereoscopically, do a complete retina examination. So in total, just to put it in perspective, a unilateral disc edema may not always be an isolated unilateral pathology, may actually be reflective of changes that are happening in the brain, which may be asymmetrically presenting to us, or else may be part of a systemic disorder which we are not picking up. So it's important to examine the disc carefully, examine the rest of the retina, and try and find out, based on the clinical appearance, what the cause may be. And thank you very much for your attention.